What, what's more, we've got ourselves nice weather, which is at least on the West Coast. I live 10 minutes bike ride from where the American border hits the Pacific Ocean, just so you can put me in place. What we're going to do over the next hour or so is a 50,000-foot view, a little bit about addiction, the disease, and a whole lot about recovery. I was asked to talk about neurobiology, and Courtney probably knows I pushed back a little bit on that request because although everybody loves to talk about neurobiology, it's not where the exciting stuff is. I know it's something that's just intriguing, and I love to hear that I had a disease that you could actually point at something being wrong. It wasn't just that I was a flawed human being. There was something they could see there, and that's all true. But I think I'll make it clear why I don't want to focus excessively on the neurobiology. So we'll talk a bit about the disease, a bit about neurobiology, and a whole lot about recovery. For those of you who've heard me before, you're going to see some of the same slides and some of the same information. But you know, a little review isn't a bad thing. And talking about recovery, I've been doing it now for a long time, and I can't talk about it without feeling good. So I think it's a worthwhile venture. So we're gonna talk about, we'll start off with the brain changes. Well, we'll start off with definitions and then brain changes. And then we'll look at what we've learned from researching people who are in recovery from addiction. Because as the author of The Natural History of Alcoholism, George Valiant, who was once an AA trustee, but he was a very famous psychiatric researcher. He once said, if I'm at a minefield and I have to make it through to the other side, I want to follow the footsteps that actually come out the other side. And that's why it's worth researching people with long-term recovery, because they know the answers way better than researchers do. At least they know what the answers for themselves. We're going to talk again about Recovery Capital. It continues to be a game changer, one of the most important things I've come across in addiction medicine and recovery medicine, and something that you folks are really familiar with, and that's communities of recovery. So let's just start with the definition. Everybody here knows it, but addiction is a chronic, this is the American Society of Addiction Medicine and the Canadian Society of Addiction Medicine. So it's a chronic disease. It's complex, involving brain, genetics, the environment, and life experience. People with addiction, and my drugs of choice, by the way, were primarily alcohol, but being a physician with ready access, there was never a mood-altering substance that I didn't like and get into problems with, including injecting some of them. But I can equally get addicted to a number of other activities, especially if they make me feel good. So we use substances or engage in behaviors that become compulsive. And even though they cause us harm, we keep doing them, which is just insane, isn't it? And this is a quick and easy look at the population of people and their use of substances. 40% of the population chooses not to use. That includes people like us who used up our drink tickets. But you know, the prevalence of recovery, I don't know, this may surprise some of you, because of the stigma. Most people who once had a problem with addiction don't advertise it, and we're anonymous. And it's estimated that in the United States, there's over 25 million people who don't have addiction, active addiction right now, but once did. So it includes those. So we're looking at 85% of the people either don't use or use substances in a way that doesn't cause problems. And then there's this thing called mild substance use disorder. And that's probably includes the people who, under periods of stress or bad times or celebration or in college, overuse, but it's a matter of quantity. They have a few consequences, but they haven't crossed that line, that where something changes. Now, some of us were born with that or cross that line, some with really strong genetic predisposition. And you hear them say things like, right from my first drink or drug, I was gone. I couldn't control it. But having evaluated like over 5,000 people in my career, there's lots of people who didn't cross that line until later. A combination of events occurred to push them over the line. And then it's a progressive condition, which the further down you go, the harder it is to come back. And it just takes more work, but there's never a state at which you can't recover. So for people who like a black and white, all or nothing answer, addiction's not for you because it's complex. So it's caused by genetics and mental and emotional factors, and there's lots of other comorbidities or other conditions, medical and psychiatric conditions that play into addiction, make it worse and get worse because of addiction. And the epigenetics is that really, really interesting. In the last 20 years, we've learned that it's not just our genes, it's not just what we inherit on our chromosomes. Those chromosomes can be either turned on or turned off, the genes on them, by our environment, by what we're exposed to, and by our behaviors. And the really spooky thing about epigenetics is that once those genes are turned on and become and express themselves in the form of a disorder or disease, in some cases, it's been shown that they can be passed on to offspring, which is really spooky. And then it involves a substance or an activity. And then there are all these other, so trauma plays a role. What your peer group did, especially as an adolescent, how young you were when you first started using. So the more you can delay it if you're a parent, the better. Pricing and availability, stigma, making marijuana legal as it is in Canada, I told people, but they weren't interested in hearing it, that when you make it legal, more people will use it, more people will have problems. And well, that's exactly what we're seeing in places where we've legalized it. Attitude makes a difference, and having problems, especially learning problems in school, makes kids a little more likely to develop addiction. The thing is, addiction, it's like the elephant and the blind man. Anybody who says, I know about addiction, it's always caused by, whatever comes out of their mouth next is wrong, because it doesn't reduce itself to a single. So if somebody said addiction is always a result of trauma, no, that's not true. Sometimes trauma is a major contributing factor. So it's just be aware that if you tend to be black and white, you want things clean, all or nothing, addiction and what works and pathways of recovery, it's crazy making because it's gray. So the answer is yes, and that yes, it's Gabor Mate, you're correct. Trauma is often a component of developing addiction, but you know what? Often it's not. So here's the brain stuff, simplified. Just so you know, I'm not anti-neurobiology. In the 1960s, I was working in a lab doing neurobiological research on rats and rewards. And reward, that's the circuitry in the brain that's involved in addiction. And we knew a little bit then, we've learned a whole lot more. If we still don't know very much, it's still pretty much guesswork. And really, the answer to brain disease, see, the problem with calling addiction a disease of the brain is it means, oh, people who treat diseases should be the ones to treat addiction. Well, partly, but not really. And the other thing is that if it's a disease of the brain, there's probably a drug to fix it. But once we look at the necessities and the components of recovery, that's just goofy. The thought that a medication, once a person has developed full-blown addiction, no simple thing like a medication is going to provide lasting relief or remission. You need more than that. So the parts of the brain, and George Koob has done a lot on this, the parts of the brain, the frontal part of the brain, which we use for our judgment, our executive function, it's called, becomes hijacked. The basal ganglia, which are responsible for our craving, our drives, our urge, which result in binging and intoxication. And then the amygdala, the emotional part of the brain, especially the part responsible for fight, flight, anger, fear, and withdrawal, that anxiety, that driven, that urgency, they play together in a vicious cycle, worsening cycle, especially with the thing called neuroadaptation. Neuroadaptation means that when you expose the brain to a certain stimulus or a drug, like alcohol, it adapts to try to get back to normal. So what used to get you high no longer does, because neuroadaptation ups the ante, takes more and more to feel good. And then at the end, some of you, many of you probably remember, it didn't matter how much you drink, you couldn't feel good. You could barely feel normal, and that's neuroadaptation. And that will gradually reset. The most exciting thing about brain neurobiology is neuroplasticity. And that idea is that neurons that wire, you're always making new neurons, especially if you're like Courtney and you're doing a lot of exercise. One of the reasons that I exercise so much, now I exercise so much because I'm an addictive sort of competitive athlete, but one of the reasons that regular athleticism is good, especially in aging, is that it stimulates the creation of new brain cells, and learning lays those cells down. And that's like putting new roofing on a roof that's got a hole in it. So you don't, the hole's still underneath there. You've still got that addicted brain underneath. But when you practice new skills, you create new circuits, and they get stronger and stronger and stronger. The line is what fire together, wire together. So you end up with it. And that's the most important thing that I can think of when it comes to recovery and neurobiology. So when we're training recovery coaches or people who work with addiction and say, you know, they're not like other clients that you're going to have. They look like it, especially during the pink cloud. We look really good and normal, but we're not yet often. For one thing, that part of our brain that increases the cues and the triggering, the basal ganglia, mean that if in our early recovery or not so early recovery, if we're around the wrong folks, the wrong situations, we can be triggered so that just being in that situation can cause us to release the neurotransmitters like dopamine that make us feel high even without the drug. And that's why, from a neurobiology point of view, it's really, really important for newcomers into recovery to avoid some of those cues, those triggers. The brain is desensitized, so we can no longer feel okay, and we just go around feeling miserable. And that takes a while to come back, and it takes more than time. We'll talk about what some of the recovery activities are. The brain stress, the extended amygdala, is on hyper alert. So we're irritable, restless, RID, restless, irritable, discontented, but we're jumpy. We don't sleep very well. And especially with the sedative hypnotic drugs like Valium, the benzodiazepines, alcohol, barbiturates. And that can take a long time to go back to normal. Executive function, that's the frontal part of the brain. And we look back at our behavior and some of the things that seemed like a sensible thing to do. And we weren't even drunk at the time that we did, where, I don't know about you, but I did some pretty goofy stuff. And it's because that I was off a quarter turn in my prefrontal lobes, and that'll come back. But again, it takes a while. And that's part of the role of a good sponsor and an accountability group for the newcomer. And then all of this impaired function will usually, most of it's reversible, but here's the thing, and this is an important bullet when I'm trying to educate my psychiatric colleagues who don't know very much about addiction, is that extended withdrawal syndrome that is often blocked. You don't notice it so much during the pink cloud if a person's having a really good first few weeks or months, and then they go into a period of saying, I don't know what's wrong. I feel worse than I did when I was out drinking. That the mood swings, the agitation, the poor sleep, the short temper, that is part of prolonged abstinence syndrome, and it's prolonged addiction withdrawal syndrome is technically what it is. If a person who hasn't had a drink for 6 months, or a Valium, or an opioid like an Oxy, ends up in a doctor's office saying and giving them all their symptoms, it's quite likely that they're going to get diagnosed as bipolar 2, or anxiety, or depression, or bipolar 2, or ADHD, or one of those, when they may have those things, but it's much more likely that they just have this syndrome, and what they need is exercise, good nutrition, a whole lot of meetings, and connection to human beings. Now, this is another way looking at the pickle slide, but it's for another reason. This slide is the epidemiology taken from both the United States and Canada stats. And we already talked about abstinence and people who used without problems. And then we get going up on the pyramid, we get to the people, the 8% of the people who may actually, who drink and drug too much. It causes consequences. And then they cross the line, and it's not obvious when people have crossed the line. So a person may or may not actually have addiction. The further you go up this pyramid, the more intense the intervention required. So at the bottom part, we need to be doing prevention, even in people over the age of 30, although they're much less likely to get it. I once had a retired dean who developed alcoholism at age 70. He did not have it before then. So there's always a role for prevention. Natural recovery is something that doesn't get spoken about, but because we don't see it. I'll give you an example of natural recovery. I had a woman with real alcoholism who came into my office, and I, being a young buck in AA, and I knew everything, I cut to the chase and saved her a whole lot of time, told her she was an alcoholic and what she had to do. And she didn't take kindly to that. And she was rude, actually, as she walked out the door. She came back a couple of years later just to rub my nose in it, and she looked wonderful. She was in a business suit. She was healthy, robust. And so I figured she must have found her way into treatment in NAA, and because she was healthy and her life was good. It wasn't just a dry drunk or anything. No, I said, what did you do? And she said, I joined Amway. And I thought that's nutty, but actually it's not. It as we'll talk about the components of recovery, she actually met her needs, partly because she had lots of what you'd call recovery capital. We'll talk about that. So addiction, I'm going to tell you something, listen carefully. The majority of people who catch addiction are going to recover, okay? Of all the chronic diseases I treat as a doctor or treated, as an active doctor, addiction has the best prognosis. So the majority of people, over 60% or so or more, are going to recover. The majority of them aren't going to require treatment. Okay. So as we go up, so we've already, because of the size of the pyramid, those invisible people that never get talked about in the press, the people who give us the bad name for the disease of addiction, are the more obvious ones. And think about sample selection. So when I'm talking to somebody in the treatment center who's got an intensive treatment center, they work in that, and I say, what do you think the rates of recovery, well, the relapse rates are? And they say, oh, it's 90%, not that many people are going to make it. And for their crowd, that might actually be true, but that's sample bias. Those of us who could get well on our own, or by going to AA, or by going to outpatient treatment, never would have seen them. So they've got a sample that they look at and they look like they do badly. And when you get to the top of this pyramid, and that's what most of the to-do is about, the homeless folks who have severe addiction and some comorbidity, although when you treat the addiction, so much of the mental illness will actually disappear. And they require everything we can throw at them. And for some of them, they require long-term palliative harm reduction. But the interesting thing is we also see recoveries from that group too. So just so you understand it, most of the population thinks when they're talking about addiction, they're talking about the top 7% there. And it just isn't so, but most of us nowadays think about it. How many of your neighbors know you're in recovery? Because there's still stigma. We don't broadcast it. So what is recovery? Now that's, if we're going to measure something, if we're going to try to achieve something, we need to be able to define it accurately so it's measurable. So one of the Betty Ford Foundation, the Institute, formed a consensus panel of experts. And since then, the World Health Organization and SAMHSA and many other organizations have come up with definitions, but they all have some things in common. So it's voluntary. Person seeks out a state that requires maintenance. It requires lifestyle change. And there's three components: sobriety, and some would say that's not the same thing as abstinence, but for most of us, addiction, people who are become pickles, it is the same thing. But I hate to admit it, but there are a few of the people who are down close to the pickle line who actually, it isn't true, but we won't get into a fight over that. So it's sobriety. In other words, you're not getting drunk, you're not showing signs and symptoms of active disease. Improved health, that's mental health and physical health, and citizenship, which means proactive behavior, communications, involvement, relationships, giving back. It's the stuff that we do, that old timers do. So it's a great definition, and actually it's measurable. So what is necessary? If somebody said, and those of you who are at ICSA in Toronto where I talked, my topic I think is God necessary for recovery in AA? And of course, the answer to that is no. What is necessary, and this has been fleshed out and is pretty much accepted. The neat thing about this is that it works for both mental health and addiction. The number one is connection. Addiction is a isolating condition. Show me a person in active addiction, even in a crowd, and I'll show you a person who's very alone. And establishing those interpersonal connections is everything. And then what happens, we don't even know we do it when we meet the newcomer or they come into the meeting. But two things happen. They look at you guys and us and they say, maybe I can do it. I was trained about hitting bottom is you got to have enough pain to enter recovery. But that's only half the story. I've met a lot of people on the streets who've got more pain than I ever could imagine. But what they don't have is the H. They don't have the hope. So you need enough discomfort to make you want to change, but then you need to be able to believe, to hope that it can get better. The identity piece is AA is, and mutual support groups like AA, but especially 12-step is wonderful because there's a new identity. I can identify now as a person in recovery because I already have an identity, but it's as a user with all of my friends who use or drink. AA is full of meaning and purpose, and it's human beings have an essential need for life to make sense to them, and the construct of what we get people started at, and 12-step meetings are really a kindergarten to get you going, because after that you're going to be working on your own meaning, which differs for everybody in this room, but it's essential. And empowerment, this is a disease of power. You know, initially we gave our power to alcohol, and then if treatment worked, we gave power to the treatment provider, and then we had to take it back. But here's the dilemma: is I can't do it alone, but I do have the ability. It's like that step 1, 2, 3. I believe that with your help, we can do this, and I believe I will. Step 3 is where I turn the handle on the door, and that's where but the power has to come from someplace, and it comes from the power of the community. At least I believe it does. Okay, now I took part in the Canadian arm of this. United States did theirs in 2013, and UK and Australia had already done theirs. So in 2015, we started this, and we surveyed, we recruited people in recovery who identified as having once had a problem with alcohol and other drugs and no longer do. 855 of them responded, and we asked them everything about what it was like, what the consequences of their substance use, how it changed, how it got better, what legally, health-wise, relationship, all of that functional stuff, and also what they used for resources. This is really important data. And the interesting thing is that it was Australia, United States, UK, and Canada came back with the same data. So it's fairly reliable. And what we found is, first of all, they defined recovery as more than not misusing substances. They described things like improved health, repair of the relationship with community and other people, and enhanced life meaning and purpose. And so when they're describing people in recovery, they're talking about people who've really changed. Their character has changed and their lifestyle has changed. Okay, so and this is measurable stuff, and it's stuff that should get the government's attention because it saves a whole lot of bucks. People who meet this description aren't using up healthcare dollars. They're not in the back of a police car or in court or in jail, and they're much more likely to be volunteering to do those vital community things that communities need. So, some more findings. Here's a surprise. Of the 855 Canadians who responded, 51% of them didn't have a single lapse or relapse once they met the criteria for the beginning of recovery. Their lives got better, surprise, surprise. Every part of their life got better. Here's the interesting point. They didn't just use AA or a treatment program. They found that they did things, and the list is endless. If you ask Courtney, you'd say, well, you gotta be athletic, you gotta be doing this and this and this. But I bet there's people in this room who would say, no, I don't do that, but I work with animals, or I'm an artist and my creative work is really important. So our resources that become an integral part of recovery vary. We used to think that the biggest barrier was the lack of resources, lack of services. Ain't true, okay? It was, people didn't know that they had addiction. They didn't know that recovery was a possibility because we're also secretive. They never see us out there. And so they didn't know where to go. And the stigma kept them hidden from asking for help because it's just such a shameful disorder. And that it still is, unfortunately. Okay, this is a busy slide, but what it looks at is treatments or resources for therapy, because AA isn't a treatment. Nobody does something to another person, but most of these other ones could be listed as treatment because it's somebody actually doing a therapeutic maneuver with another human being. But the first column of numbers is what percentage of the group used them, and the second column is, do you rate it as very important in your recovery? And 12-step programs were rated extremely highly, partly because of sample bias. I think they were more likely to respond to the request, but our request was widespread. We had a lot of Indigenous folks, like 9% of our respondents were from First Nations. And people who went, the second one in the list, people went to treatment, which was 61% of the sample. They valued it highly. 83% said, yeah, I really, really needed to do that. Now, if you go down the list, one of the more interesting ones is third from the bottom, medication-assisted treatment. 20% of them had medication. That's like Suboxone or methadone or one of the drugs to assist treatment. And it was important, but not that important. 42% of them say it was important. So for my colleagues, I show this slide because they think for there to be a treatment of addiction, you have to have medication. And I'm saying, you know, that'd be nice, but there's more important things. There's things that work more effectively than just medication. And for the very bottom one, if you've got Indigenous folks, only 5% of us used culturally specific treatment resources, but it's very, very important that they do. Having that reconnection, that sense of identity, purpose, meaning, and empowerment they get from it. So it's something when we're teaching recovery coaches is if you've got First Nations people, Indigenous folks, and there's a cultural group that they could get back to, get them there. They can do a better job than you can. Okay, recovery capital. That is all of those things that you have that get you into recovery and then keep you sober. I was in the treatment center with a guy named Guy. He was a roommate for a while, and he taught me an awful lot. And he said, I remember the one thing he said when we were getting some very high-powered psychological lectures, and I was having trouble following, and he says, don't worry about this bullshit. When you get out, just go to meetings and get a sponsor. And you know, I listened to him, and it was an important bit of advice. Guy is dead. Guy died many years ago because he could never get sober. He was way ahead of me. What was the difference? Well, he lacked recovery capital. The next slide is going to show you a whole bunch of examples of recovery capital. So it's such an important player. Like if you're working with people with addiction, you want them to evaluate the recovery capital. And the other thing about recovery capital that you need to know is that it's a dynamic, it's like the capital balance in your bank account. It goes up and it goes down. Further into addiction, it goes down, you lose stuff. Further into recovery, if you're working on recovery, it continues to increase. People divide recovery capital into 3, 4, or even 5 domains. This is just a very partial, limited list. Physical things that either can be barriers or they can be resources to make it more likely to get into recovery and strengthen your recovery. But first of all, you need to be safe. You need to have enough food. You need to have a roof on your, if you don't have those things, the rest is kind of garbage. That's like Maslow's hierarchy of need for those of you who took that in university. And they need to be looked after. And then all of the other things are And there's many, many more that I'm sure the people in this room could fill 3 pages with different kinds of recovery capital, but these are sort of the once over lightly. I spend most of my time over on the final column because I'm working in building communities of recovery and recovery community supports like recovery community centers, training recovery coaches, campus recovery programs, and recovery friendly workplaces. Here's an interesting slide. It's don't take it literally. It's a graphic, an infographic. But basically, if you look at time on the x-axis and quality of life and recovery capital on the y, the vertical axis, from the moment you get into recovery, and the start of recovery is hard to define. I bet you if I asked people in this room, when did your recovery start? You'd have different answers. Some would say the moment I picked up the phone, but you may not have had your last drink yet, but you were desperately pursuing something. So, but anyway, from the start of recovery, emotional quality of life will go up very fast because all of a sudden there's hope. And that's what we call the pink cloud. And very frequently that lasts a while. And then there's a period of feeling less well. And that's where it becomes really important to be tied into a group of support. People who can, remind you that just because you feel bad doesn't mean you're doing badly. And then gradually with time, it continues to increase. And I'll tell you, I'm 75 years old and I'm 36 and a half years into recovery, and it continues to get better. That's no lie. As long as I continue to do the things I need to do that I've learned that work for my recovery. And so recovery capital is a dynamic balance that changes with effort and time, but you need to identify those components of recovery capital that you want to work on. And the stages could be defined variously. Oops, I need to go back. The stages from initiation going through the stages, early abstinence, maintenance, and long-term recovery. It'd be interesting to get people's definition in this group if we had the time for what is long-term recovery and what is maintenance. The reason that John Kelly puts the line at 5 years is 5 years of recovery is the point at which your relapse risk falls in a population of people in recovery. The risk of relapse by 5 years uninterrupted recovery drops to the general population. So that's where you can't breathe a sigh of relief because we've always got that risk in the background. We've always got that pickle status to go back to. So but it's what it is. This is some of the tasks that we've had to do, and they'll look familiar to you. We had to grow up, especially if our drug was marijuana, and we started when we were 13 years old. You're a 30-year-old stopped smoking doobies who is 13 years old emotionally. But we do catch up. It just takes a while. We have to figure out what our strengths and weaknesses. That's where our recovery capital comes in. We need to learn to say no, how to manage my emotions and bite my tongue, and how to set boundaries. People from addicted homes, people in AA and in recovery often have difficulty recognizing boundaries, setting boundaries. They've got thin skin, things get in, but they're also often have difficulty recognizing other people's boundaries. It's worth learning them. Al-Anon's a great place to start. Getting over myself, getting right-sized again, all of those things. I don't have to talk to you about all of those skills, but they're all related to my level of recovery capital. So as I build these skills, as my recovery capital increases, it's like an insurance policy. My resilience, my resistance to relapse goes up. So I'm way, way less likely to relapse. I can share these slides with everybody when I'm done. I think you're recording this, but if you want the slides, I'll send them to Courtney. This is my yin yang slide, and it's my yes and. Like, the thing about treatment of disease, treatment of addiction, is if you take a person with really severe addiction and you treat them successfully, you've got a person who no longer has active addiction, but that's it. Recovery is something that happens in the community after treatment, and it's a long-term thing that happens between people. I forgot to tell you an important factoid, and that is one of the most exciting numbers that I've heard in the last 2 years was a piece of research by a researcher by the name of Litt. And he did research, reliable, high quality human research that showed when you take people with addiction and you compare them when you're treating them, if you hook that person with active addiction up with another human being who's in recovery from addiction, get them hooked up, a year later, their likelihood of being in recovery, just doing that thing alone, their likelihood of being in recovery is 27% higher than the other group. You could say, that's not much. Well, it is. It's massive. We don't get that kind of outcome from medications for any drugs or treatments. That is amazing proof of connection of why our 12-step group just suiting up and showing up and going to the meetings is so effective. You know, it's magic. Now, this next slide is a little philosophical. Bear with me. And it's my doctorhood talking here. So I spent years and years and years. I thought I was a healthcare provider. They called me he's a healthcare provider. Well, I wasn't a healthcare. I didn't know shit about, I didn't know very much about health. I knew a whole lot about disease. But that does not mean I know anything about health. So whether I was treating addiction, depression, PTSD, heart disease, or even cancer, treating those, and I can be the best cardiologist in the world, but unless I get beyond, so I could bring people up to the ground level here, but I didn't have the language, I didn't have the training, I didn't have the skills. What do they need to do after they begin the process of recovery? Once they're in remission, once the treatment is done, or the person is no longer actively addicted or actively diabetic, their blood sugar is normal, or they no longer are having cardiac arrhythmias and they're not getting a lot of chest pain, what then? Well, the thing I found, and I'd be really interested in Courtney's opinion on this, when I hang around with people, long-term recovery from diabetes and heart disease, and they've reversed their diseases, and I meet them in my running groups and in my triathlon groups and in activity groups, cycling groups, their lives, their recovery, their activities are identical to mine. What I've learned is recovery is recovery. When you're recovering from a chronic lifestyle disease like addiction or heart disease or depression or cancer, and these are all self-inflicted diseases, by the way. I hate to say it. I mean, people say, gee, those addicts deserve it. They did it to themselves. Well, come on. As a doctor, if you want self-inflicted, look at heart disease. That's self-inflicted disease. And just like with addiction, who's responsible for recovery? It's up to the person. And people will. If you give them the tools, people with heart disease will do what we do and get into recovery. So here's what I had to learn, and just take a moment and read through this top part of this slide. These are the things that are important for going up that mountain of recovery from all chronic illnesses. Okay, their lifestyle medicine. Okay. All right. I'm going to be opening for question in a couple minutes. I'm ahead of schedule, but I've never had anybody complain that my talk was too short. So why is, and I'm so delighted that secular recovery has come on the scene, because it got so, as a doctor, I was embarrassed to be sending people, and I could say, quite honestly, AA has better outcomes than most of the treatments that we recommend as treatment providers, as doctors. But because so many of the groups are so rigid and so fundamentalist, at least in Canada, it wouldn't sell, not with my young patients. They go in through the door and say, what? But now that secular AA is around, they're much more likely. But that's where Smart Recovery is recruiting all of its people. And Smart's fine. It's just not as good as 12-step, for, in my opinion, for a couple of reasons, but they're technical reasons. I think the 12-step traditions and the 12-step process, the ingredients are brilliant. And so, and most important is they work. So they provide community. If there's somebody at that meeting who has what I need to learn right now, because I've got a gap in my recovery capital, when either Moose or there's been a number of researchers who've teased out what happens in AA, what type of psychotherapy modalities are woven into AA. And there are many different ones, like cognitive behavioral therapy and network therapy. And there's a lot, and motivational interviewing, we do it all the time. So there's a lot of woven. One of the criticisms of research comparing 12-step facilitation therapy, where we send people to AA, comparing it to other types of treatment, is people who know AA says, well, that's not fair, because when they go to AA, they're getting all those other things too. And it's true. So people who go and connect with 12-step it's a strong predictor of recovery. And there's a growing variety of mutual support groups out there now, Life Ring and Women for Sobriety. But I'm delighted that we have secular 12-step now. It's in Canada, it's growing rapidly. Secular recovery is growing. AA is actually shrinking in this country. The surveys are showing. This is my final slide. For years and years and years, I had to take it when my colleagues would look at me with sarcasm and a little bit of pity and say, well, you got to say that stuff because you're one of them. Well, actually, now we've got the most high level of research evidence available on anything. The Cochrane reviews, when a treatment makes it to the Cochrane Library and with a strong recommendation, it's gold plated, it's gold. And it basically, the first Cochrane review of AA was damning, because that came out in 15, 20 years ago, and it says there isn't enough evidence to show that AA works. It didn't say that AA doesn't work, it says there isn't enough evidence. So since then, a huge amount of research was done, and now there's evidence that shows that AA for alcoholism, and I think we can generalize about 12-step programs for other addictions as well, works at least as well and better than most any other treatment modality. And remember, AA is not a treatment modality. So if you send somebody to AA, they're much more likely to be sober than other groups. And that evidence, the interesting thing is the people who oppose 12-step and AA still oppose it. They're still just as strong. They just don't refer to it. They just don't refer to it. They still talk about evidence-based, and it means they're going to talk about a medication or something that works, but AA works better. So just so you know, and I'm going to stop sharing. Well, actually, I'll go to my summary slide, and then we'll open it up for questions. So in summary, sure, it's partly a brain disease, but I used to ride horses, and I wasn't a very good horse rider. And when my horse would put its ears back, I was in trouble because that means my horse was pissed off and was going to buck me off. And I could have invested in tongue depressors and taped them to his ears to keep him up, because his ears would go down before he'd buck me off. The thing about all of this effort working on the problems in the brain is we can diddle and fiddle the chemicals and the circuits and the anatomy of the brain all we want. But I think we'd all agree that addiction, and especially recovery, is something that goes way, way beyond what's going on inside the brain. There's just too much to it. Most of the brain changes are reversible, sometimes quickly, sometimes slowly. Most people with addiction do in fact recover. That's very good news. CHIME, connection, hope, identification, meaning, and empowerment, and the game changer of recovery capital. If a treatment program does not demonstrably increase recovery capital, we shouldn't fund it, because that's all its job. Get people's recovery capital up and they're going to do well. And recovery is not an event, it's a journey, and it doesn't end. Okay, I'm going to stop sharing and turn it back over to Courtney, if I can figure out where my cursor is there. Okay, all yours.
Thank you so much, Dr. Baker. We really, really enjoyed, I'm sure everybody enjoyed your presentation. The thing I always appreciated about your ability to communicate these things is you take complex scientific subjects and you make it so real for us. We're not all scientists, we're not all doctors, and often the science goes over our heads, and you do it in such a common sense way, with good common sense. So thank you so much for your presentation today. I love it. We did record it, and in fact, I'm going to stop the recording now, and you'll hear that briefly. And